very much greatly enjoy having this symbiotic relationship with the Vista Center in our practice to be able to provide state-of-the-art care to all people with low vision. So the goal of today's talk, we're going to talk about two topics. Mainly diabetic retinopathy and age-related macular degeneration. So really the goals of today's talk, we'll briefly review some quick objectives, and then once again, as Alice had mentioned, feel free to ask any questions throughout the presentation, because there's going to be a lot of information and it's going to be hard to remember as the slides go through. So just raise your hand, we'll stop, take a question, and answer it, and then move on. So quickly, we're going to review some basic eye anatomy and define exactly what is macular degeneration and diabetic retinopathy. How do we treat these two conditions? And then talk about some exciting new research for the future. In 2013 and going forward to 2014, we are living in a very, very exciting time for ophthalmology and vision services, as every month that comes out, every year that comes out, we have exciting new treatments to help people with these conditions, not only for prevention, but for treatment. So it's a very, very exciting time. 10, 15 years ago, we didn't really have much to offer, but even since I finished my fellowship last year, there's many more things coming down the pipeline. So there's a lot of reason for hope. So just very quickly, the eye is essentially a camera. So it has a front part called the cornea. This is simply the windshield to the eye. It lets light into the eye. Most commonly, this is the part that people have LASIK surgery on to reshape the cornea to reduce their dependence on glasses. The light that gets focused through the lens of the eye, that basically focuses the light onto the film of the camera, which is the retina. The lens of the eye most commonly develops a cataract, and people have cataract surgery later in life. The most sensitive part of the eye and the retina is called the macula. That is responsible for the best 20/20 vision, reading, driving, recognizing faces. Just like a camera, the retina is like the film in the camera, so it's what absorbs the light. The entire eyeball is attached to your brain with a small little wire called the optic nerve. The optic nerve is what most commonly gets affected in people that have glaucoma. So this is a diagram of what, or a fundus photo or a retinal photo of what the eye doctor sees when they dilate your pupil. So we're looking through the cornea, looking through the lens, looking through the clear jelly of the vitreous, and focusing on the optic nerve, and then the macula. Once again, this is the part that gives us the reading, driving, recognizing faces, and close work. The most precious part of the vision comes from the center. So, two most common causes of vision loss in the United States. It's basically broken down by age. In the age group of 20 to 60, it would be diabetic retinopathy, which is more of the working class population, and age over 60 would be macular degeneration. If you go to the third world, most common causes of vision loss and reversible vision loss would be cataracts. So we'll briefly go through diabetic retinopathy, and then once again the bulk of the talk will be on macular degeneration. Once again, feel free to stop and answer or ask any questions that come up, and I'd be happy to answer them. So what is diabetic retinopathy? It's essentially caused by the body's inability to regulate the blood sugar. And as we know, there's two types, type 1 and type 2. Type 1 commonly happens when you're younger. Type 2 happens later in life. And diabetes, it's important to recognize that diabetes affects all blood vessels in the body, the retina, the kidneys, and the nerves. As ophthalmologists, we're very fortunate because we can actually dilate the eyes and directly see what's happening with the blood vessels. Other doctors don't have that benefit, but whatever's happening in the eyes is really a reflection of what's happening throughout the rest of the body. So what happens is, over long term, not 1 or 2 weeks or 1 or 2 months, but many, many years of uncontrolled blood sugar, you get damage to the small blood vessels. And it can cause leaking and bleeding inside of the retina and vision loss. So what do people with diabetic retinopathy see? So normal vision would be on the left, and on the right would be a schematic of what you might see with diabetic retinopathy, or a person with macular edema or swelling in the retina. It's very splotchy vision, and pieces are missing from swelling. So who gets diabetic retinopathy? Both type 1 and type 2 diabetics can get it. About 50% of people with diabetes have some form of diabetic retinopathy, and as we'll see in the next slides, it varies. There's mild, moderate, and severe disease. And the most important thing to remember to prevent the onset of disease and to prevent it from getting worse is regular monitoring of your blood sugar and controlling your blood sugar with your internal medicine doctor, primary care doctor, or endocrinologist. That's the most important thing that you can do. So stages of diabetic retinopathy include non-proliferative, which are mild, moderate, and severe. And I'll show you pictures of all these. It'll make a lot more sense. And then proliferative diabetic retinopathy, where you get growth of abnormal blood vessels on the surface of the retina, which is your body's response to compensating for the lack of blood flow that happens. So this is, again, a colored photo of what the eye doctor would see after he dilates your eyes. In the most mildest cases, which roughly 20 to 30% of people that have diabetes may have, is you basically get very small little blood spots in the retina. At this stage, very, very few people have any symptoms. They may not even know that they have any damage to their eyes. So that's why it's very important to obtain a dilated eye exam with your regular ophthalmologist, and they can pick this up. When it develops into a little bit more moderate and severe disease, you get a little bit more blood spots and some yellow compounds that leak out of the blood vessels, and this is essentially what we call lipid exudate, or fat and protein that is leaked out of the blood vessels that are now becoming leaky. And as this happens, you can develop swelling and vision loss. The more severe case of diabetic retinopathy happens over many, many years, and in response to your body's inability to regulate the blood sugar, your body wants to make new blood vessels to compensate for that. However, those blood vessels are not normal. You would think it's a good idea for your body to make new blood vessels, but they're not normal, and they cause leakage and bleeding. And if it bleeds a little bit too much, it can bleed into the middle part of the eye, called a vitreous hemorrhage. The most advanced form of the disease, which we really don't see that often now, which is really good because people are more aware of the disease, leads to scar tissue developing on the surface of the retina. And this is usually treated by surgery in the operating room. So, causes of vision loss. There's really two ways that people can lose vision from diabetic retinopathy. On the left is a normal fluorescein angiogram. This is a dye test that the doctor does in the office. It takes about 15-20 minutes. There's no pain, and we just measure the circulation in the retina. So this is a normal black and white photo of what a normal test should look like. And on the bottom is a small scan called an OCT, or optical coherence tomography, which is a non-invasive scan that takes 2 seconds to do in the office, and it's analogous to, say, a CAT scan that you would have of your brain or your abdomen. It takes very thin slices to see if there's swelling. So on the left is normal. On the right is what happens when you get swelling from diabetes. So sometimes on the picture, or on the color picture, you can't see any of this going on until you get the testing. So you can clearly see on the right all of the white spots that are leaking, and on the bottom, the scan is very, very thickened with those black spots. So that's swelling in the retina. And oftentimes people don't know that this is happening. You would not know this until you come in and get an exam. So fortunately, we can treat this. The swelling can be treated. The former gold standard of this, as of probably 5-10 years ago, was to do a laser therapy in the office. It's completely painless. It takes probably 5-10 minutes to do, and the doctor takes a localized laser and can pinpoint the little white dots, and the swelling can go away. Oftentimes it takes maybe 3 or 4 months for the laser to kick in, but it tends to last a little bit longer. Sometimes you need repeat treatment. So that used to be the former gold standard, and we still do that a lot because it works quite well. Now, as of about 2012, latest and greatest treatment now is a medicine called Lucentis. So in response to the lack of blood flow in the eye wants to make a new compound that grows new blood vessels and causes leakage and swelling. And that compound is called VEGF, vascular endothelial growth factor. We'll talk about this more later as it pertains to macular degeneration as well. But now people can come into the office, and on a monthly basis or every 2 months, they can get a small injection in the eye of medicine that's used to treat this very swelling. It's important to realize that with the medicine, it works very, very well, but just like a medicine you take by mouth every day for blood pressure, diabetes, or other reasons, the medicine goes away, and you have to take it every day. For this medicine, it only lasts probably 4 to 6 weeks in the eye, and then you have to come back and do it again. So, more causes of vision loss. So we talked about swelling in the retina, and that can be treated with the injections. So once again, on the left is a normal angiogram, black and white photo of the blood flow and the circulation in the retina. That's normal. On the right is what happens with severe uncontrolled diabetic retinopathy. And the area highlighted in yellow All the black area is parts of the retina that is not getting enough blood flow to it. And if it gets to this stage, unfortunately, some of this is irreversible. We do not, as of yet, have medicine to bring back the blood flow, but we can treat it with laser and these injections to prevent it from getting worse. So ideally, you want to come in and get normal, routine eye exams to prevent it from getting to this phase. So this, on the right, is proliferative diabetic retinopathy, where the body has started to make new blood vessels. So the treatment for this is to do a laser on the eye, a larger style laser, to reduce the bleeding, and that's shown in the right. All the little white spots are the peripheral or side laser marks that have been done. Good question. So the question was, the shot or the injection that you get in the eye, is it covered by Medicare? And it is covered by Medicare, yeah. All of these issues that we're talking about are medical issues, so they're all covered by insurances.
This shot really scares me, because they have been, they've been saying they're going to do that to me, so I haven't been back to the doctor. Is there a way possible you could do it without the shot sticking in your eye?
That's a really good question. So whenever you talk about getting as your mother may have told you growing up, you better watch out, you're going to get a shot in the eye, right?
Yeah, right.
No one wants to have that happen, and that's very, very anxiety provoking, and we all understand that. So the procedure only takes about 2 seconds to do. There's a little bit of discomfort, but there's really not any extreme pain to it. So no one wants to get it done, but you can ask a lot of people that have gone through it before, and they can tell you that it's fairly easy to do. And obviously that's easier said than done for me, being the physician, but it's a pretty benign procedure, and it does work. So,
what would be the percentage of people you think that show improvement, or do they show complete or partial improvement from the shots?
yeah, good question. So in the big clinical trials that were done with the Lucentis medicine for diabetic retinopathy, people got an injection every month on the month for roughly 6 to 12 months. And at the end of that 12 months, probably 80 to 90% of people had improvement in their vision, right? So that's opposed to the natural history of doing nothing, which is slow progressive vision loss. So those are really great odds with very, very little side effects. So the question is, can you repeat it one more time?
A diabetic, a vision loss due to a stroke is any cure?
Good question. So if you're diabetic and you have vision loss due to a stroke, is there a cure for that? So that's a little bit of a different problem. So sometimes if there's a stroke in the eye, sometimes there's permanent damage from lack of blood flow. So it kind of depend on a case-by-case basis. So it's I'd be happy to talk to you more after that, though, after the talk. So any more questions about, yep. The name of the medicine is called Lucentis. Yep. So we're going to talk about another medicine called Avastin also that is also used for this condition, and a third medicine also that was just approved probably about a year ago called Eylea. We'll talk about that. Any more questions about diabetic retinopathy? Okay, so now we're going to shift gears and talk about macular degeneration, a very hot topic for obviously this talk and also for retina specialists. So what exactly is macular degeneration? So it's a disease of the retina that slowly or rarely rapidly can damage the center part of the retina called the macula. Again, the macula is responsible for the sharpest vision, reading, driving, recognizing faces, doing close work. Most common cause of vision loss in people older than 60 in the United States. So once again, this is a similar picture to what was shown before for people with diabetes. Again, it's a condition that affects the center part of the eye, the macula. So on the left would be a normal image of what people would see. On the right is a central blur spot. So it's very difficult to read, to recognize faces. Again, this is a schematic of a paragraph in, say, a textbook, and the center part is very, very blurry. So often people have to move their head around or find a very fine pinpoint area to get good vision. So it can be very, very frustrating. So this is just a schematic from the National Eye Institute detailing the degree of vision loss based on your visual acuity on the chart. And progressively from right to left would be an increased blur spot. So key points about macular degeneration. People are obviously very anxious when they come to the doctor and they may have this diagnosis, but key points to remember is this is never a condition where you will live in complete darkness. The center part will be affected and there will be a smudge in the middle, but it will never take your side vision or peripheral vision. So that's very, very important to understand. So the psychological impact of people with macular degeneration is quite significant. Studies have been done showing that patients with low vision are 2 to 3 times more likely to be depressed. So that's why it's very important to get involved with groups such as the Vista Center that can offer a lot of support and counseling for people with low vision and help you to become more functional with the vision that you have. So key risk factors for macular degeneration are broken up into non-modifiable, things that you can't do anything about, and modifiable risk factors. And key non-modifiable risk factors include age, over the age of 50 or 60, Caucasian race, family history, and female gender. Modifiable risk factors include cigarette smoking, diet, body mass index, and physical or relative lack of physical activity. So how do we classify macular degeneration? So basically it's broken up into 2 different types, dry and wet. 90% of people have just the dry form, 10% of people have the wet form. So it's important to realize that the dry form is extremely slowly progressive, whereas the wet form can be slightly more rapidly progressive and causes the bulk of the vision loss. Up until probably 2 or 3 years ago, the bulk of the research and still ongoing research has been done to try to treat the wet form of the disease because that is what's responsible for more of the vision loss. Just now, as of 1 year ago, and we're going to talk more about this, there's a lot more research being done in how to treat the dry form of the disease and to prevent it from getting worse. Question?
Use of DRUSEN is on the left.
Good question. Next slide. Yep. You got the slides beforehand. So yeah, what are drusen? So drusen are basically an accumulation of metabolic waste throughout a person's lifetime. So every day, the retina has cells in it that degenerate and then they regenerate. So byproducts get broken down, and then they get built back up. They get broken down, they get built back up as the retina processes the light. Over time, some people call it wear and tear, kind of like arthritis that you might have in your joints. You get accumulation of metabolic waste or byproducts called drusen, and they get deposited in the retina. That's all that is. So the driest early form of the disease, which can only really be seen after you get a dilated eye exam, includes the accumulation of these very, very small pinpoint drusen. And often at this time, there's really no vision loss, and this can just be monitored over time. A more intermediate dry macular degeneration is classified by slightly more drusen or the size of the drusen. And often here, vision may be impaired, but often it is very normal. More advanced form of the condition includes having some drusen, but more than that, there's already been some damage done or atrophy or degeneration of the central part of the retina. And if you can see, it's tough to see in this image, but the optic nerve is on the left, and in the center is the macula, and the area in the yellow circle is area of atrophy. So you can kind of tell that the central area would be quite difficult to read, drive, recognizing faces, as those are cells that aren't functioning. So now the goal of current research is to focus on how to limit the progression of that atrophy area. So wet macular degeneration, once again, happens in 10% of people with the condition, and it's characterized by abnormal blood vessels that grow under the retina. So the blood vessels can leak fluid, and if left untreated, may progress to a scar. The analogy I like to use for my patients is similar to weeds going through cracks in a sidewalk. So over many, many years, through wear and tear, there's slight breakdown of the retina, accumulation of drusen, more drusen, and then suddenly you get blood vessels that can kind of go through and under the retina. Question?
Doctor, has there been any experimentation about removing this?
Great question, yeah. So probably 20 years ago, when we didn't really understand what was happening, people tried several techniques. People tried to laser drusen in the office. That didn't work. That only made your vision worse. And then people even tried to do surgery under the retina to remove that, and that was not a good idea either. That made your vision much worse very quickly. So it has been shown that trying to remove the drusen does not help. Very good question. Any other questions right now on the classification? So this is the end stage of wet macular degeneration, and this can lead to a scar, which is basically the yellow and whitish area in the middle. Just like the more advanced form of the diabetic retinopathy, which we don't see, we fortunately do not see this very often now because we have such good treatments to maintain the vision. So how do we diagnose macular degeneration? Many of you are familiar with this eye chart, but basically the doctor will check your vision and have you read the letters on the chart. The top letter is the big E, represents 20/400 vision. Down at the bottom represents 20/20 vision. Another thing that we use to diagnose macular degeneration is what's called the Amsler grid, and basically it's just a graph with straight lines, and some of the symptoms of having swelling or bleeding under the retina include having distortion or straight lines starting to look wavy. So that's a very important symptom that everybody should be aware of. And the key, I saw somebody doing it in the audience, is to check each eye individually. If you have both eyes open and one eye is good and one eye is bad, you may not notice any distortion. So it's very important to close one eye and check each eye independently. And often we see people that have already had some chronic problem and they just all of a sudden notice it. So every once in a while it's important to notice this. You do not have to have this grid. So what I tell patients is you can look at any door frame, you can look at any picture frame that has a straight line, and you can still test your vision this way. If there's a slight bend or a crook in it, then there may mean something is going on. So other ways that we diagnose. We've seen this picture before. This is the fluorescein angiogram. Basically, we inject a small orange vegetable dye through your hand. It takes 20 minutes to do, and we can measure the circulation in the retina to see if there's leakage or bleeding. So on the left, once again, is the normal picture, and on right you can see the whitish leakage from the dye, which represents abnormal blood vessels growing under the retina. Another important test, which we briefly showed you a picture of, is the optical coherence tomography. This is slowly becoming more and more popular and not replacing the angiogram, but we're learning with better technology on the OCT scan, we can get a very, very high resolution picture of all of the layers of the retina. The retina may seem like a very thin film, but it's actually composed of 10 different layers. And for the first time, probably as of about 3 to 4 years ago, with this technology, we can isolate exactly where the swelling is. And that's important for prognosis and treatment options. So on the top is a normal scan. The normal dip in the middle is called the fovea. That needs to be there. That's what gives us the best 20/20 vision in the center. And as you can see, with the growth of abnormal blood vessels, there's a little bump or a dip underneath the retina, and there's swelling, which is represented by the black spots. So how can we, before we talk about treatment, how do we prevent macular degeneration? So the key to prevention is early detection and diagnosis, meaning getting regular, routine eye examinations so someone can look at the retina. Also, lifestyle modification plays a very large part in the prevention of this. Smoking cessation is paramount. Exercise, maintaining healthy weight, maintaining normal blood pressure, and also proper nutrition. So how do we treat dry age-related macular degeneration? Most of what we're going to talk about is the wet form, but we have some very, very exciting new clinical trials even for the dry form. Up until probably 1 to 2 years ago, the mainstay for treatment of dry macular degeneration was based on eye vitamins and routine surveillance. We didn't really have a good medicine to treat the dry form. We have powerful medicines, which are the injections in the eye to treat the wet form, but the dry form, we really only have the vitamins. And the vitamin recommendations are based on a very large clinical trial conducted by the National Eye Institute, which is a part of the National Institutes of Health in Washington, D.C., looking at thousands of patients, roughly 4,000 to 5,000 patients, that took a very specific formulation of vitamin C, vitamin E, beta-carotene, zinc, and copper. So if you took these vitamins, this study was completed back in probably 2003, 2004. This was the AREDS-1 study. We're going to talk about the follow-up study here in a second. So if you had even intermediate or advanced dry age-related macular degeneration, you had 25% reduced risk of progression of the disease if you took this specific formulation of vitamins. Now I highlighted the terms intermediate and advanced because many times patients ask us, my mother has it or some family member has macular degeneration, and should I take the vitamins? That's a very difficult question to answer without actually looking at the person, because even people that have the early dry form of macular degeneration had no benefit from taking the vitamins. So that's important. Just because some doctor tells you that I have macular degeneration, I should probably take these vitamins. If you actually look at the clinical trial data, only people with intermediate and advanced forms of the condition benefited from the vitamins. Question?
The vitamin E, it's been supposedly known for being for bleeding. So if you take it for the dry, but you're having, you got wet, and are you not encouraging bleeding?
That's a really good question. There's been from this study, there was no increased incidence of conversion to the wet macular degeneration based on that.
Is it a matter of the amount of vitamin E?
It's probably, yep, exactly. Yeah, every medicine that you take by body, whether it's blood pressure medicine, or medicine for diabetes, is completely dose dependent. So probably the more you take of it, your risk increases.
I have a question
Uh-huh.
about that Amsler grid. I'm 90 years old, and I just have slight wavy lines in the grid. Is that normal for my age?
Yeah, so a little bit of wavy lines is normal. So what you really want to kind of pay attention to is if there's any sudden change. So if you've always kind of had some wavy lines, it's probably okay. But if all of a sudden you wake up one morning and there's a change, that's probably something to be aware about.
Thank you.
Question?
I'm familiar with all of the vitamins except the duplic oxide. Could you go into that?
Yeah, it's copper is supposed to reduce the risk of side effects from the zinc. So that's what was informed. We're going to talk more about that here in a second. Okay. So a follow-up study was conducted starting in 2006, the results of which were just released in May 2013, so no more than 5 months ago. So everyone was very excited in the ophthalmology community to see the results of the AREDS 2 study. And basically, this was a study looking at the addition of additional antioxidants, lutein and zeaxanthin, and also the addition of omega-3 fatty acids. So even before the AREDS 2 study was conducted, even in the AREDS 1 study, the investigators wanted to study this, but due to some commercial availability of some of these vitamins, they weren't available. So that's the real reason it was not being able to be studied prior to that, starting in 2001. But some of the scientific data behind the addition of the antioxidants and the omega-3 fatty acids comes from the cardiovascular literature. So if everything is, or something is good for your heart, the eye doctors thought, well, it should probably be good for your retina and overall health also. So they looked at the addition of lutein and zeaxanthin and also omega-3 fatty acids. As we know, omega-3 fatty acids are largely found in fish, and the antioxidants are found in green leafy vegetables such as spinach. So those are all good things to add to part of your diet if you don't already include them. But very, very interestingly, as kind of a surprise to the entire community, there was no added benefit of the omega-3 fatty acids. So interestingly, over the last 5 years, as the study was going on, pharmaceutical companies were already manufacturing vitamins with the new formulation in mind. And people would come to us asking if I should take these vitamins, the AREDS 1 vitamins, or some combination of the two. And it can obviously be very frustrating as a patient to figure out which vitamins would be most beneficial. But now, at the conclusion of the study, we realized that the omega-3 fatty acids at the dose given in the study were of no additional benefit. So that's very important to realize. What we did find was that in the first study, people that had a history of cigarette smoking and took the original formulation with beta-carotene, there was a slightly increased risk of having lung cancer. So we no longer use beta-carotene, and we can substitute that with lutein and zeaxanthin, which are similar antioxidants. So, question?
I've been advised, in addition to the normal vitamins, to take a combination of lutein and fish oil for the reasons that you described. But when you go to a drugstore and you look for lutein, there's 6 milligrams, 20 milligrams, 40 milligrams, and it was never specified to me what is probably the optimal dosage.
So the question was, what should the optimal dosage be for the eye vitamins? Yeah, so this is a very, very common and a very, very frustrating problem that patients have. And the real answer is complicated, right? So, yeah, so if you look at the numbers and you go to the drugstore and you pick up 6 different bottles of eye vitamins, the dosages are going to be different, okay? So really, the only practical recommendation that one can make is the dosage that is given in the clinical trial, which was 10 milligrams of lutein, 2 milligrams of zeaxanthin, and then the omega-3, which you can see. If you take that specific dosage, then you can extrapolate the clinical trial results and say that you have some benefit or don't have some benefit. If you start varying from that dosage, saying I'm going to take more or I'm going to take less, well, it's very difficult to then make a recommendation from that. So I can understand the frustration because a lot of patients come and they try to kind of make their own formulation because they're taking something, but their primary care doctor wants them to take a multivitamin, and the multivitamin often has some other component in it. So it's very hard to see what the interaction is, but I can see the frustration there. More questions about vitamins? So this is hot off the press. Just as of May of 2013, the ARIDS 2 study results were released. Question?
There is a discussion about chemicals in nature that have a direct effect on
I am not aware of that chemical in blueberries. I can look that up. Do you know the name of the chemical? Okay. I think blueberries are good for you in general, right?
Yeah.
Always good for the eye.
So talk about those last two unpronounceable acids.
I'm going to let you pronounce them. I can't pronounce them. I'm going to call them DHA and EPA.
Is that what you look for? They're unfamiliar to me.
Yeah, so those are the breakdowns of those specific omega-3 fatty acids.
Oh, those are part of it?
Yep.
Okay.
Those are the two types of the omega-3 fatty acids. Question?
I take Preservision that has lutein in it. Is there any benefit to also taking lutein?
You take Preservision with lutein, is there any benefit of taking additional lutein?
Right.
Yeah, great question. So it kind of goes to this other gentleman's question. We don't have the answer, right? So if you already have the lutein in the Preservision at 10 milligrams, you're probably okay. There's probably no need to take additional lutein.
Is this change? The original study said there was no benefit from the omega-3 fatty acids, but now they say there is?
No. So what I'm saying is in the study, they studied the addition of omega-3 fatty acids, and at the bottom, the conclusion of the study showed that there was no added benefit.
But you said these other two, the unpronounceable, are types of fatty acids?
Yeah, the slide is wrong. So the omega-3 fatty acids, that's a subgroup of the DHA and the EPA. DHA and EPA are a type of omega-3 fatty acids.
So that means all three of the bottom ones are no added benefit?
You got it, yep.
Just the lutein and zeaxanthin?
Zeaxanthin, correct. What's your question? Question?
Bansal, I just wanted to clarify. So are there some, I missed part of the last slide, but so would you add in vitamins, any vitamins to that zeaxanthin lutein in your recommendation to people, or just lutein and zeaxanthin?
Would you add additional vitamins?
Just lutein and zeaxanthin, or would you add the vitamins on the previous page?
Yeah, so the good question. So the standard formula of the ARIDS 1 formula still stands at vitamin vitamin C, E, zinc, and copper. So that's the base formula. And if you have intermediate or more advanced dry macular degeneration, this reduces your risk of progression by 25%. So the really only recommendation that came out of it was it's okay to eliminate the beta carotene, as that was associated with the risk of lung cancer, and you can add lutein and zeaxanthin. Taking additional omega-3 fatty acids at this dose was shown to be no additional benefit. Now, whether omega-3 fatty acids at that dose are good for your heart or other cardiovascular health, they probably do help, but they don't help at that dose for the eye.
So does that mean that the lutein and zeaxanthin, there was an advantage?
Say that again?
Does that mean there was an advantage to the lutein?
No added benefit, correct.
Well, because the bottom says no added benefit of omega-3 fatty acids.
Yeah.
But there was a benefit.
But does that include?
So good question. So the study, the ARIDS 2 study, is a lot more complicated than, we're trying to boil it down here, but the lutein and zeaxanthin can basically replace the beta carotene, and you still have that 25% risk reduction. Yeah. If you really look at the data a little bit more closely, people that take lutein and zeaxanthin, there was one subgroup of people that actually had a benefit, and that was people that had very, very low levels of lutein and zeaxanthin in their diet at baseline. But that we can talk about later. That's a very, very small subgroup of patients. So who should take the ARIDS vitamins? So really, as we talked about, to kind of hammer the point home, it should really be people that have intermediate age-related macular degeneration or advanced dry macular degeneration, which can really only be diagnosed by a dilated eye exam. So even if you have the early form, patients do not really benefit from the ARIDS vitamins. So very important points, which I think touches on this gentleman's first question. Vitamins will not cure macular degeneration, but delay its progression. That's very, very important to understand. A lot of times people get started on the vitamins, they come and see us 3 months later, 6 months later, and they ask, how come I can't see any better? So that is not the goal of the vitamins. The goal of the vitamins is to delay its progression, okay? And vitamins will not restore vision that is already lost. Very, very important to realize. So precautions about vitamins. We talked somewhat about this, but smokers should probably avoid taking beta carotene. And now from the AREDS 2 results, we know that we can safely substitute lutein and zeaxanthin, and you don't need beta carotene. There's some genitourinary symptoms with zinc, and some interaction with systemic medications have been reported. So exciting new research for dry macular degeneration. So there was a clinical trial that was just completed probably about 2 months ago, and it looked at an intravitreal injection, or same injection that you would get for the wet form of the disease. And when given every month for 2 years, for people that had dry macular degeneration, this is a complete paradigm shift. We used to think as about 5 years ago, you can really only do the injections for wet macular degeneration. But for the first time, researchers have studied a medicine that you can actually inject for dry macular degeneration, and it showed a 20% reduction of the progression of the atrophy. So that's very, very exciting because we had no other way to prevent the progression aside from the vitamins. Question?
My husband had wet and had all the injections.
Mm-hmm.
He does not bleed anymore, and the doctor believes that he's gone into dry. That's what I was finding. So would it help to have that?
You've asked a very, very philosophical and important question. So there's, if you look at I'll repeat the question. So your husband had wet, and now it's basically, let's call it inactive. There's no more bleeding, and we think it's the dry. Would we benefit from these injections? Very good question. So there's a philosophical debate that eye doctors have about what the natural history of dry versus wet macular degeneration is. Some people think that the natural history of wet macular degeneration, even though it's treated, leads to dry macular degeneration anyway. So some people think that before you can even have the wet form, you always have the dry form. Does that make sense? Yeah. So, unfortunately, sometimes if you have the wet form, there's already been some damage and scarring despite the injections. So that's not the garden variety dry form that you might think of before conversion to wet, in which case this medicine may not benefit. This medicine was used in people that strictly had the dry form, no history of wet. Okay, so it's very hard to extrapolate these results to that condition. Does that make sense?
Yeah.
Right. So this, again, very, very small study, maybe 100, 200 patients, and really only phase 2 data. So we're just kind of tipping the iceberg here. So they're going to do a larger study to see if this actually pans out. The important thing to know that with dry macular degeneration, it moves at a snail's pace. 1 year, 2 years, 5 years, 10 years. So this was only a 2-year study. So it was a 20% reduction, but who knows, maybe if people got injections for another 2 years, the risk reduction may be 40 and 50%. We don't know. It's too early to tell.
What about if you have wet macular degeneration in the right eye and dry in the left eye? Does that have any connection with this? We used to before, if you have wet, this may not help. But
Yeah, it could possibly help for the dry eye, for the eye that has not converted to wet. Yeah, that's a good question. So if you have wet in one eye, you're getting a different type of medication or injection. If you have dry in the other eye, perhaps this medicine would work also. We don't know.
Was that me?
Yeah, go ahead.
I was invited to such a trial, and I declined because they said that the trial involved 3 different dosages of the injection plus a placebo. So I figured, well, if I entered this, I'd have 1 in 4 chances of getting the right one. Have they focused on what is the appropriate dosage?
You touched on a very good point. So this is the dilemma that we face in conducting clinical trials. So we all like to be very, very scientific to be able to offer the latest and greatest treatment. With any clinical trial based on the FDA, the Food and Drug Administration, that heavily regulates the safety of these clinical trials, you number one have to have some type of a placebo group. You cannot just give someone a medicine and study the effect. That would be kind of unfair. It's also unfair that if the medicine works and you end up in the placebo group, then you may not get the benefit, right? That's the caveat with enrolling in a clinical trial. Okay? So the other caveat to what your question was, there has to be different dosages, because that's where they study the safety of the medicine. So they do a small dose, usually a middle dose, and then usually a higher dose to see what is the safety. That's simply mandated by the Food and Drug Administration. If you look at any clinical trial for blood pressure medicine, diabetic medicine, what have you, it's just the way they conduct it.
But did they conclude which one had the most effect?
For this specific one, I have to go back and look at the numbers.
Okay.
Yeah.
Are these treatment for the dry form by injection, is that available now?
Good question. So this was just a clinical trial that just got completed a few months ago. So this is not quite yet FDA approved. They have to do a larger clinical trial.
They have to do a stage 3?
You got it, yeah. Stage 3, phase 4 clinical trial. So another very exciting research that's being done for dry macular degeneration is no one, as we talked about, really wants to get this injection in the eye, right? So if you can do away with the injection procedure, then maybe we can give someone a medicine by mouth that would also prevent it. That would be a little bit better, right? So we have a very new clinical trial that's actually enrolling right now for people that have dry macular degeneration. You take one pill by mouth at night for roughly 2 years, and it's supposed to reduce the risk of progression. So this is still enrolling right now, very, very early data, and we do not have any results yet. So it's a multi-center clinical trial, and it's really geared towards the people that have not so much drusen, but they have the atrophy part of it where they've already lost some of the cells. But in the early clinical trial data, it seems to be working. So this is also very, very exciting because it's not a procedure, it's just a medicine you take by mouth.
Since they're enrolling patients, how do you get connected?
Yep, so you can call our office, and we're one of the sites that's enrolling patients, so you just have to come in and get an eye examination, and if you fit the criteria, then you might consider participating in it. So this is very important because the paradigm for dry macular degeneration up until last year has been take your vitamins and cross your fingers, right? Sorry, we don't have anything for you, but now, because we've kind of headed in the right direction with wet macular degeneration, researchers have more time to focus on the dry form. Number one, the goal will be to prevent the progression if you already have it, but ultimately I think in 5 to 10 years, we're not too far off, it's going to be to prevent it completely. So hopefully you want to get to the phase where you don't even develop the atrophy. So that's something to look forward to. Any questions about dry macular degeneration?
The question back to the drugs, the vitamins.
Vitamins.
If your doctor tells you to take, in my case, eye caps, and I've been taking them for 12 years, is that an ARMD qualified vitamin?
Yeah, eye caps should be, but I have to see the exact label.
It
you know?
says xanthan and the other.
Yeah. So there's probably, so unlike regular medicines that are kind of heavily regulated by the Food and Drug Administration, the FDA, pharmaceuticals, or I'm sorry, vitamins and nutraceuticals, as people call them, are not so heavily regulated. So many different companies can manufacture a lot of different types of vitamins, and unless you read the actual package, you don't exactly know what you're getting. So you have to kind of be proactive and read exactly what's in those different vitamins. That's a really good question. So we're going to shift now to wet macular degeneration if there aren't any other questions on dry. Okay, so wet macular degeneration, as we talked about, is caused by abnormal blood vessels that grow under the retina. Again, using the cracks in a sidewalk and weeds going through the sidewalk analogy. So we're going to briefly talk about past treatments because it's very important to realize where we have come to figure out where we're going in the future because we have exciting new treatments for wet macular degeneration. But I always like to put it in context of what was available in the past. So before we had any of these powerful medicines we could put in the eye that are biologic agents, we were a little bit primitive, okay? We'll admit that. We're not ashamed to admit that. We didn't really have many options. But we used to use a hot laser. So someone talked about, very astutely, bringing up the point that why don't you just take the drusen out, right? You can laser it or you can have surgery. Well, we thought, let's hit it with a laser. There's some blood there and some vessels there. Why don't we zap it with a laser? We're really good at doing that. Well, that does a good job of reducing the blood vessels that are growing, but it does a really good job of putting a scar in the center part of the retina. So we said, hey, congratulations, we fixed your problem, but you can't see. Okay? Not a very good treatment. Well, we got a little smarter. We figured out, let's use a cold laser that's a little bit more selective. So this was called photodynamic therapy. We would inject a small molecule through an IV, and it would be activated by a very specific laser. We would target only the area of the abnormal blood vessels. Well, that did a really good job also, and this was the latest craze probably maybe 10 years ago. But the caveat with the laser was it would stop it for a period of time, and people, instead of losing vision over maybe 6 months, would lose vision at 12 months. So it's better than losing vision. If you have nothing, if you're going to go lose vision in 6 months, it would be better to have the laser and you can regain or maintain some of your vision for a little bit longer. So good treatments at the time, but patients still lost vision more slowly. Not ideal. So current treatment options for wet macular degeneration in 2013 going to 2014 have been heavily involved with this molecule that was also involved in diabetic retinopathy called vascular endothelial growth factor, VEGF. And it plays a very important role in normal and abnormal blood vessel development. So normal fetal development, normal wound healing, but when out of sync or out of homeostasis, as they say, it can lead to cancer, wet macular degeneration, and also diabetic retinopathy. So there's 3 molecules that we have now. They're all biologic agents that target specifically this molecule that gets released inside of the eye. The first one is called Lucentis or ranibizumab. The next one is called Avastin or bevacizumab, and the third one, the new kid on the block, is called Eylea, aflibercept. They have very bad generic names, hard to remember. So what exactly is Lucentis? It's a small antibody molecule that specifically targets that one molecule inside of the eye. And as we discussed with the treatment, it can be given every month or on an as-needed basis. And if you follow the clinical trial protocol after roughly 1 year or 2 years of treatment, with the treatment, you have a 90% chance of maintaining all of the vision that you have when you first walk in the door. Roughly 33% of patients improved vision. This is a radical new departure from our past treatments with any type of laser. So previously we used to tell people, you have the condition, we'll do a laser, you might lose vision a little bit more slowly. For the first time, you can actually tell people, well, you have a 90% chance of keeping all of the vision, which is alone dramatically better, and you actually have a 1/3 chance of improvement in vision. So that's very, very, very exciting. So this was approved back in 2006. So this is a small little graph. Don't worry about the details, but basically, if you're on the top half where the Lucentis is, you actually gain vision. If you're at the bottom part of the graph in the green, that's where the cold laser is, you lost vision. So for the first time ever in the history of this condition, in the last 50, 60 years, you actually have a good chance of improvement of vision compared to the natural history or the prior treatment. So what is Avastin? So a lot of people, there's a lot of debate going on whether to use Avastin or Lucentis or the new medicine. If you came to us probably 6 years ago, we only had 1 or 2 choices. Now we have many, many more options that work equally as good, if not better, than some other ones. So it's a very similar medicine to Lucentis. It was actually initially developed to treat colon cancer when given systemically through the IV. It's also given as an injection in the office every month or as-needed basis. So the medicine Avastin, as it was initially developed to treat colon cancer, is used off-label, meaning it's not FDA approved for the indication that we use it for. But if you look at, they've done a survey of 3,000 retina specialists across the country in the United States. Roughly 70% of retina specialists use Avastin as first-line therapy because it works equally well to Lucentis, and it's a fraction of the cost. So we live in an era that's governed by insurance companies and other healthcare providers, so cost is definitely an issue with all of these medications. Just as an off note, Avastin is roughly $50 a dose. Lucentis, does anybody know how much that is?
About $2,500.
You got it. Right? So a fraction of the cost. So prior to some clinical trials that were released about a year ago, retina specialists used to think, hey, Avastin works equally as well. So we didn't have good scientific evidence, but we thought in our minds that it's working equally as well because our patients were doing very, very well on it. Well, the National Eye Institute conducted their own independent clinical trial looking at hundreds and thousands of patients comparing Avastin to Lucentis, a 2-year study, and they both came out equally well. So now we have very good phase 4 clinical evidence to suggest that Avastin is equally good as Lucentis. Another study identical to this was conducted in Europe, the results of which were just released probably 1 or 2 months ago, called the IVAN trial. Again, looking at thousands of people, Avastin versus Lucentis, equal. So now we have very good evidence to suggest that both medicines are equal, although one is not FDA approved for it.
Why is one so
Yep.
Yeah, we have RP in our family, 3 daughters and my wife, etc. Atypical RP. So it's not diabetic, it's not, macular degeneration. You're saying that a doctor can give this, I forget the term you used, but
off-label.
Off-label.
Yep.
Do you think a doctor, we're working at UCSF with doctors there, in Berkeley Eye Clinic, do you think that doctors would be able to try that with their family?
For retinitis pigmentosa?
Yes.
Yeah, very good question. So retinitis pigmentosa is a very, very different disease than these diabetic retinopathy and macular degeneration.
Okay.
So, to my knowledge, VEGF, or vascular endothelial growth factor, which what these medicines target, is not implicated in the pathogenesis of retinitis pigmentosa. So I don't think it would, number one, work.
Right.
So even though it's off-label or on-label, probably, yeah. Exactly.
Okay, thank you.
Good question.
Is there any way to account for the difference in price for Avastin versus Lucentis?
Do you want to take a guess?
Different company?
No, it's a funny point. It's the same company. It's made by Genentech here in San Francisco.
Oh, well.
So it's not in their best interest to have a $50 medicine and also market a $2,000 medicine.
Well,
This
why
is
are they doing that?
good question.
Well,
It takes money.
got the answer.
Yeah.
It takes a lot of money to go through the clinical trials and get FDA approval. It
Absolutely.
takes quite a lot of money, and so the company is trying to get their money back for that one.
That is the right answer. That's how they justify it.
Yeah.
So, another caveat to these medicines, and we're going to talk about the third one, is some people respond very well to Avastin, some people respond very well to Lucentis, and some people respond to anything you give them, and some people don't respond to either one. And you can switch the medicines back and forth, which is what often we do when one we think is not working. Okay? So in the clinical trial, everyone's biology is different. If you have it in both eyes, sometimes one eye responds to one medicine and the other eye responds to the other medicine. So it can be very hard to predict what happens. So oftentimes it's a little bit of a trial period to see what's happening with the medicine. So there's no firm, strong recommendation to say that Avastin works the best in this person and Lucentis works the best in this person. That's very, very important to know. Okay, so this was just another graph of the CAT trial comparison of age-related macular degeneration treatment trial, Lucentis versus Avastin, and you can see that the lines are essentially equal. So at the end of 52 weeks or 1 year, people that were randomized to either Avastin or Lucentis had equivalent outcomes in vision. So who's the new kid on the block? The new kid on the block is called Eylea. It's a very similar medicine to Lucentis and Avastin. I tell my patients, think of Avastin and Lucentis as twins, okay, same mom and dad. Think of Eylea as maybe a very close cousin, okay? So it has a slightly different mechanism of action, but it's also given as an intravitreal injection, and it can be given every month or every 2 months. In the clinical trial, the big advantage or theoretical advantage of this new medicine was to be given every 2 months as opposed to every month. Okay, so that would be theoretically reducing the number of injections with the same clinical benefit. Since this was just approved in November of 2011, we're using it more and more, and we're gaining more clinical, real-life experience with it. And what some retina specialists are finding is that it doesn't actually last as long as we thought in the clinical trials. So that's something to be aware about.
What does it cost?
About the same, yeah, $1,900, $1,950. Yeah. So again, it is FDA approved for wet macular degeneration.
Cost?
What was that? Cost?
The cost?
Yeah, so they're about the same, $1,900, $1,950. So think of Lucentis, Eylea around $2,000. Good. Any questions about the 3 different medicines?
Is there any treatment or medicines that can curb this?
Yeah, so these are the 3 different medicines that we use to treat the wet macular degeneration, given as an injection, yeah. There's no...
The percentage of improvement in the study?
Yeah, really good question. So the numbers I quote patients are 90% chance of keeping all of the vision stable, 30% chance of improvement.
For Eylea?
Yeah, they're all the same. So Eylea was compared to Lucentis, and they came out the same numbers. 90% chance of stabilization, 30% chance of improvement.
Have you seen results with Eylea when the other 2 medications that you look for?
hit the nail on the head, right? So this was the latest talk probably 6 months ago at all of our national meetings. People were having patients treated with Avastin or Lucentis and say they weren't responding, so people would switch them to Eylea. Okay, so let me give you a little background on that. So a lot of studies were done looking at that exact phenomenon, and what it showed was that the Eylea makes the fluid under the retina go away if you switch it. However, the vision sometimes does not get better. And the reason that is because these patients have already received Avastin and Lucentis, and they're a little bit of a different population that are not responding. So if you look at the bulk of the patients, they respond to Lucentis, Eylea, Avastin, whatever you give them. But a small fraction of those patients may not respond and still have fluid on their scan. So if you give them Eylea, it can dry up the fluid, but the vision may not necessarily get better.
So because it's drying up the fluid, does any vision that they have change in any way?
So good question. So that's another frustrating thing that we deal with, is that there's often not very good correlation between the vision, meaning subjective or objective on the chart, and what the pictures show, which can be frustrating. Sometimes people can have very, very good vision on the chart, and there can be a lot of fluid on the OCT. Vice versa. Sometimes the vision can be quite poor, and there's no fluid on the OCT. You know, so it's very hard to predict that. It's kind of a case-by-case decision, but very good questions. So what are the risks of the injection? They're extremely, extremely safe procedures. You take maybe 5 minutes to do in the office. The main complaint that patients often have is some surface redness and irritation. More serious side effects of the injection are extremely rare, 1 in 5,000, 1 in 10,000 risk of having an infection or a tear in the retina. So this is just a brief summary of the treatments that we have for macular degeneration. Before 2006, we could only slow the progression of the condition, okay? As of 2006, there was a complete paradigm shift in how we manage this condition, in which now we have 3 different medicines, Lucentis, Avastin, and Eylea, that effectively can treat the medicine. So it's a good time to kind of pause, and often people ask, am I cured of this condition? So I think cure is really not the appropriate word, but we are treating it and managing it is more of a better expectation. Because as soon as you stop the medicine, the fluid invariably does come back at some point under the retina. So you tend to need ongoing treatment because, as we talked about, Lucentis, Avastin, Eylea only stay in the eye for maybe 4 to 6 weeks. Future treatments, and we're involved in some of these clinical trials that are going on now, is to find much, much longer acting medicines, and even implanting something in the eye surgically where you can refill it in the office. It can last 6 months to 8 months. So there's a more exciting treatment modalities where you don't have to come to the office every 6 months or every month. You can just maybe come once, come back in 6 months, and then get another one. So that's where the paradigm is shifting, because as the next question arises, often we now have a good treatment, it works, 90% stabilization of vision, 30% chance of improvement, but the question invariably comes up, how many injections do I need, and how often do I need to get them, and for how long is this going to go on, doctor? So those are very, very common questions, and very appropriate questions. And as we're getting more experience with the medicines, we're slowly trying to answer some of these, and that's the goal of future research. So what are any questions about the medicines?
Since the fluid buildup is the threat to vision, is it necessary to have an examination showing that fluid level before every injection, or when?
It's a very smart audience. These are very, very good questions. So as physicians and retina specialists, we struggle with what to do with this fluid, okay? The classic dogmatic teaching is that any fluid under the retina probably should not be there and you should treat it. Well, we know that there's a certain percentage of patients that have persistent fluid on their scan only. They're asymptomatic, they have good vision, and we can only pick it up on the scan. Okay, and that can sit there for maybe a year, 2 years, 3 years, and it doesn't do any harm. Okay, so just having fluid on the scan doesn't necessarily mean you have to get an injection. Okay, this is what we're learning also, because if you flash back to the, where's that? If you remember what that OCT scan looks like, that technology is very, very good at picking up even microscopic amounts of fluid that we could not even detect 5 years ago based on our old technology. So just because we can detect it on the scan doesn't mean it's necessarily clinically significant. Does that make sense?
Yes, but How often should that scan be done is really what I'm asking.
Again, it's a case-by-case,
Case-by-case.
yeah. They're actually working on newer technology where probably the next, I would say 2 to 3 years, they're going to probably have a home monitoring device that can get that same image. We're not quite there yet, but they're working on that. Good question. So they used to think before we had these medicines, why don't we give a diuretic such as acetazolamide or Diamox medicine by mouth? It doesn't do anything for that type of fluid. And you can take a diuretic, similar style medicine in an eye drop form, and they've tried that also. It doesn't work. Question?
Yes. I was wondering, I know this is dealing with diabetic issues, but what if you have like more like cataracts and a disease called polypoidal retinitis? Are any of these new drugs helpful for that condition?
That's a really good question. So polypoidal is a subset of macular degeneration, and obviously it's much less common than macular degeneration, so there's no large-scale clinical trials looking at this medicine. But there's several smaller-scale clinical trials looking at the same medicine for polypoidal, and it seems to work. Now, we don't have larger randomized trials saying Avastin is better than Lucentis is better than Eylea for that condition, so we're really extrapolating this clinical trial data to that condition. But this medicine does nothing to affect cataracts. That's a good question. So another treatment for swelling under the retina that they used to use a long time ago, we still use it for other conditions, is instead of injecting this powerful biologic agent, you can actually inject steroids in the eye also, like prednisone or dexamethasone or whatever you want. Prednisone is a very powerful medicine, as we know, that can be given systemically, and it can help a lot of inflammation. So we think that inflammation does play a role in these conditions also, and that, if injected in the eye over repeated times, can be associated with cataract. Steroids around the eye, even in an eye drop format. But these medicines are not linked to cataract progression. Does that answer the question?
Yeah, I mean, I'm dealing with different things in one eye.
Yeah. Yep.
So we've already been 2 years now fasting. We're waiting on the FDA trial on a couple of the others to try to stop some of the bleeding tumors. Takes out the fine vision. You have to deal with that. Whether it's considered rest. I was just curious whether or not any one of these three might be better.
Yeah, that's a really good question. There's no large-scale clinical trial that I'm aware of that studies it for specifically your condition. So this is current research on wet macular degeneration. We talked about exciting new trials for the dry form, including the oral medicine and also the injections for the dry form. For the wet form, as we talked about, the current questions, how many injections do I need and can I space them out? How often do I need to get the injections, and how long do I need to get the injections for? So the current research, this was another very early phase 2B study looking at another compound that blocks another factor that's also implicated. As of now, we focus simply on VEGF, vascular endothelial growth factor. Well, the body is not that simple. The process and the growth of the new blood vessels is related to many, many factors, so we're only blocking one of those factors. Well, this new compound targets a slightly different molecule that's released, and they combined it with Lucentis, and it actually showed superior results to just getting Lucentis alone. So this, again, a small number of patients, very, very small trial, but they're going to do a follow-up study, so hopefully this medicine may even be better than the other three that we have right now. This is just another couple slides on some current research. We're looking at newer medicines given in injection form that instead of being given every month can be given every 6 months. So reducing the frequency because they last longer. And then the other one I briefly mentioned was a surgical procedure to implant a permanent kind of depot where you can refill the medicine over 6 months. We're not quite there yet. So, any questions about macular degeneration? Treatments?
I don't mean to sound absurd, but to try and deal with the liquid, is there any kind of suctioning you can do rather than injections or
So I think,
Or laser, okay, suctioning?
so suctioning would involve actually going inside of the eye doing surgery to remove it, and they've tried that, and that does not work.
Okay.
Yeah. Good question. So what are the take-home messages? Macular degeneration and diabetic retinopathy are the most common causes of vision loss in the United States. It's very important to obtain routine dilated eye examinations, and we cannot stress the importance of leading a healthy lifestyle with healthy nutrition. We talked about vitamins, diet modification, stopping cigarette smoking, obviously much easier said than done. And the most important thing I want to leave you with is that there's quite a bit of hope for treatments to preserve vision that are coming down the pipeline every month, every 6 months. Just now we had a big meeting in, I think in August, where the results of the dry macular degeneration were released, and there's a big meeting in Europe that's going on currently, where we released the Avastin versus Lucentis data, and there's going to be another meeting in November where we're going to have more results coming down. So as the results come in, doctors scrutinize the results and make sure they're applicable to our patients, and very soon they get FDA approved and we can use them. So all of this stuff, honestly, has happened in the last 6-7 years. So it's happening very, very quickly. There's a lot of hope. Any questions? Yes?
Are there any new people being taken for the tests on phobia?
On the Fovista.
Fovista, excuse me.
Yeah, that one I believe might have stopped enrolling, but I can double check that. Any other questions?
Back to the comment about the use of steroids, you said possibly in the eye. My question is, if you need to take them internally, does that affect the eye, that relationship that you're talking about?
Prednisone by mouth?
Yes.
Yeah, very rarely. You have to take a pretty high dose of it and for a very long time. Yeah.
For the benefit of the people who are worried about the eye injection and haven't started yet, I just wonder if people would raise their hands who are now getting eye injections, you might recognize that this is fairly common.
Yeah, I think that's a really good point. Maybe we can raise our hand and see who gets the injections. Good point. Question? Go ahead.
Sorry, I can't see. If you don't mind, I can address the thing about eye injection.
Oh, that'd be great.
I've been doing it for 3 years now. I had a period where I was having a Avastin injection once a month. Basically, there's no pain. What you'll suffer more is anxiety, but after the first one, my physician, he always makes sure that, you even told another one to kind of hide your needle so you don't see it. And that's the whole big thing of it, all you see is his hand, you feel the pressure, so that's basically it. And that's my experience. And the only other thing I would make sure that you do is make sure you take the antibiotic drops that are scheduled. It makes it a lot easier.
What's the DNA factor for this disease, and is there some preventive steps you can take with your younger children?
So I think you're referring to the genetic component?
Yes,
Yeah.
yes.
So they've done, no doubt macular degeneration has a genetic component to it. And they've done many, many studies looking at genetic testing, and actually the new paradigm also will be for macular degeneration is taking someone's blood sample, seeing what type of DNA compound or makeup that they have, because that will affect who actually responds to this medicine. So they're doing subset analyses from these big clinical trials to figure out, well, if someone has certain DNA makeup, they may respond a little bit better to the DNA, but that's also in its infancy. The caveat with the genetic testing, there are some commercially available genetic tests, and most retina specialists do not routinely order that, including myself, because number one, insurance doesn't cover it. That's not the real reason. You have to pay out of pocket. But number two, we don't quite know how to counsel patients regarding the results. Okay? So if you're 30 and you get the genetic result, if your parents have macular degeneration, what are you going to do about it? We don't have any recommendations. Do you take the vitamins? Do you not take the vitamins? There's no large-scale study to suggest that. Do you start doing injections at the age of 30 if you have 20/20 vision and no signs of macular degeneration? Probably not. You know, if you have a couple drusen and you're 40 and your mother has it but your father doesn't have it and your genetic testing is still quote normal, what do? You know, so it's kind of opening Pandora's box right now. I think we're going to have a lot more information later because I think gene therapy would likely be the next phase after you can identify some compound that may be more strongly correlated with wet macular degeneration or dry macular degeneration, and you can certainly target that with a very specific agent. You know, now we have a good way to get medicine into the eye, but they're actually looking at ways to get medicine directly under the retina with surgical procedures to implant a gene compound. But we're not that far off from that, so genetics definitely are an important point, but in terms of genetic testing, I think it's a little bit right now, you have to meet it with a little skepticism.
Didn't you say that they were doing these studies to prevent it? So in other words, my grandson who has it on two sides wouldn't have.
Well, the prevention refers to having already had, if you have dry macular degeneration, is to prevent the progression of it.
But by the time he's 50 or 60?
Well, yeah, we don't know that yet. We don't have any medicine. That would be the next phase, right? So if that medicine that you take by mouth, number one, reverses or prevents it from getting worse, yeah, who knows? Maybe we would recommend that in 10 years to someone who has a strong family history. You know, we don't have the clinical trial yet for that. That'd be very interesting to look at.
Kind of diagnosed with macular degeneration with and dry, and the dry was 40 years ago. She decided to do the cataract surgery, and but after it was done, I could see very good immediately. And a month later, I left what I would quit. Do you think that is
So that's a very good question. That's a common thing that can happen, but based on the large-scale clinical trials, there's no link or association between cataract surgery and the progression of wet macular degeneration. Thank you for your time.